Good evening. I'm Marcia Thomas Brown. I'm the co-chair of the Health Executive Club.
Hey, let me see.
It's on now.
Yeah, the green is on. Should be on.
Yes, it
Got
is.
to point it towards you.
I hate these things. I said every time. Good evening. It's on.
It's turned on. You'll have to talk loudly.
Can you guys hear me without this? No, I need this? Okay. Good evening. You can tell that I will never be a hostess on television in front of the camera or whatever, because I like to do things my way, and sometimes it doesn't work out. Anyhow, I am Marcia Thomas Brown. I'm the co-chair of the Health Executive Club Program Committee, and I have the pleasure of welcoming you this evening to our educational event, actually the fall first, and to encourage you to relax, release, and relate, and be able to absorb wonderful, educated, informative, useful information this evening, because we have great speakers. The food, I think, at least from my perspective, have been great, and we have given you the opportunity to at least begin your networking. So thank you for coming. Couple of details. You received a yellow form, and we really appreciate if you complete the form telling us how we're doing and your impressions of this event. Is very useful, and it helps us to plan future events. Also, this event is being recorded, and you will be able to see it on YouTube and on our website once we complete the editing of the event. The bathrooms are out to the left and a slight left if you need to exercise your right, and so just keep that in mind. So let's get started. The Health Executive Club collaborate with a number of organizations to be able to make this particular event happen. And so a couple of things, I will welcome them in a minute, but I also would like to take the time to let you know that this building will be, next year, will be 100 years old. And I'm one of those people that I think it's just lovely. When we came to visit, we really got carried away with the architecture and the art. And so I definitely want you to be aware of where you are sitting this evening. We're doing a timely collaboration with, of course, us, the Health Executive Club, the Medical Society of the County of Queens, which have been in existence for over 100 years. Again, how many? 218. 218 years, okay? And in today's day where everything is fast and we don't appreciate good things and things that last forever, I just want to acknowledge that I do appreciate that. Also, we are collaborating with the Association for Healthcare Risk Management of New York, the New York State chapter of the Healthcare Information and Management Systems Society, known as HIMSS, the New York Regional chapter of the National Association of Healthcare Services Executive, and the Black Long-Term Care Executive, and the Metropolitan New York chapter of the Healthcare Financial Management Association. So thank you guys very much. Tonight, the topic is trends and strategies to mitigate medical liability in New York State. And of course, when we hear of healthcare and we hear of risk management and we hear of liability, we all get a bit what's happening now. Providers do, the patients do, organizations do. And so I think that this is a great opportunity for you guys to take out your pencils and take notes and ask as many questions as you're able to, because it's going to be very, very interesting. Also, we have, in order to make it interesting, we are able to provide you with 4 great speakers, experience, very knowledgeable about the topic. And so I would like to introduce you to Dr. Ayman Attia-Alla. Dr. Attia previously served as the hospitalist at the Landmark Medical Center in Woodstock, Rhode Island, and as an urgent care physician at the Veterans Administration Hospital in Fargo, North Dakota. I always wanted to go to North Dakota. I still want to go. I will go. He also provided homeopathy training at New York Medical College in Valhalla, New York. And since 2006, Dr. Attia has held the appointment of assistant professor, clinical instructor mentor at the Medical School of Brown University. He is also presently affiliated with North Shore University Hospital of Northwell Health. Dr. Attia. Also, we have with us today Jonathan D. Rubin, Esquire. Mr. Rubin is a partner in the New York City office of Kaufman, Borgeest, and Ryan, LLP. His practice areas include medical malpractice defense, long-term care, nursing home defense, healthcare, product liability defense, and general liability defense litigation. He is a former president of the Association for Healthcare Risk Management of New York and a member of the New York State Bar Health Law Section. Jonathan represents hospital, nursing homes, physicians, psychologists, social workers, and other allied medical professionals in civil litigation matters through trial in state and federal courts in New York. When I introduce you, I can go like that. Next, we have Salvatore Volpe. Dr. Volpe has 30 years of primary care medical practice experience and has achieved board certification in pediatrics, internal medicine, geriatrics, clinical informatics, and quality assurance. Dr. Volpe is the recipient of the 2007 iPro Quality Award. The award was presented in recognition of his commitment to improving care for Medicare beneficiaries, as reflected in his work to create a patient-focused environment within his practice and his work as a physician champion in promoting electronic health records and health information technology for quality improvement. Dr. Volpe. Last, not least, we have with us tonight Noah Becker, Esquire. Presently, Mr. Becker serves as the Director of Risk Management in the Metropolitan Jewish Health System. He is an attorney with years of experience defending some of New York's largest healthcare institutions against medical malpractice claims. After practicing for years in New York State courts, Noah transitioned to the role of Associate Director of Risk Management at a 600-bed academic teaching institution, where he was responsible for the strategic and operational direction of the hospital risk management department in the heart of Brooklyn, New York. In his role, he identified and evaluated adverse and patient safety events and implemented corrective actions to mitigate risk. So this is our panel. We welcome them. And if you also have a copy of their bios, I just read portions of it. And so for additional information, you can read the buyer and get the data that you're looking for. So with that in mind, are you ready?
Ready. Yes, ma'am. Ready.
Dr. Yeah.
Good evening, everyone. It is both an honor and a privilege to address you today as we stand at the crossroads of medical advancement and unprecedented global health challenges. As a president of World Medical Society and someone deeply invested in the well-being of the city and its people, I want to take this opportunity to reflect on the evolving landscape of healthcare, not only in New York, but also across the United States. We practice in a very challenging state. New York State saw the largest number of medical malpractice lawsuits filed among the country's 50th state between 2012 and 2022. Hospitals and nursing homes in New York are struggling lately with staff shortage, combined with increased patient population and increased incidence of malpractice lawsuits. The landscape of medicine is changing, and we must prepare to adapt to the new challenges we face in the next 5 to 6 years. In the next 5 years, cancer will overtake the cardiovascular disease as the leading cause of death in the US. One in 2 Americans will be classified as obese. We also have increase in mental health crisis. The suicide rate in New York went up by 34% in the last 20 years. We also have other challenges. We have antimicrobial resistance, and this is the next global catastrophe. And we also have big issues like abuse and overdose. We do have marijuana store around every corner in our New York City, and a recent study have shown that marijuana use is linked to higher risk of heart attack and stroke. Adults who use marijuana daily have 25% higher risk of having a heart attack and 42% higher risk of stroke when we compare them to non-users. So really we have a lot of sick patients in our movement. The medical field is facing new challenges, and we must discover the best way to effectively treat our patients while at the same time protecting ourselves from the increased risk of liability. I also want to introduce our medical society. Our medical society is 218 years old. We are here to help physicians. We meet every month, and the next meeting will be October 8th. And our goal in our medical society is to help physicians, to make policy, and also to talk to politicians to help our society and help our patients. I encourage every physician to join us if possible. And now we're going to start with the question to the lawyer, the doctor. And the first question is going to be about documentation and what's the best way to protect our physician when it comes to documentation, because it's the most important subject as a lawyer dealing with and the fight for these liabilities.
I can take it from here if you want.
Sure.
I can start and then we'll go.
So good evening, everybody, and thank you again to the Healthcare Executives Club for having us present this evening, and thank you to all who are attending this evening, the physicians, my colleagues, and the community here. This is really a timely event in a challenging time for the delivery of medicine and a very ever-changing litigation world. So hopefully tonight we can have a robust conversation about all these topics. We definitely invite any questions as we go along. We want it to be interactive and answer your questions and your concerns going forward in the time we have. So we're going to cover several topics. We think they're all timely and relevant to what is going on out there in the medical world and what the physicians in this audience are facing on a daily basis. So hopefully the information we impart here tonight will be helpful. And again, we're happy to answer any questions while we're here tonight. So please feel free to raise your hand, and we'll try to recognize you as we go along. But first and foremost, we thought it was really essential to talk yet again about documentation. And I'm sure everybody in this audience here tonight has heard past presentations on this issue, and it continues and it will continue to be a vital and essential issue in collaboration with the delivery of care. So I can tell you as the lawyer and the litigator and the person on the stage who defends medical professionals in malpractice actions across the metropolitan region, documentation is, a continuous issue. Good documentation always helps our defense. It always helps us understand what happened. It always helps us when we go to depositions and we go to court. We know that documentation is a challenge. We know it can be very time-consuming, very onerous, but it goes hand in hand with the delivery of good care. And it's a skill. It's one whether you've been practicing, 1 year or 30 years that you can constantly be improving at. And it's one that you should, learn from your colleagues, talk to them, and find ways to improve in what you're writing for each and every patient interaction where you need to report something. So, I can tell you, we see now a lot of changes, and we'll talk about that, about EMR and how that certainly has changed the landscape tremendously in the past several years as the EMR has become the way that records are kept, across hospitals and medical institutions across the country. It's definitely changed a lot from when I started, and it was all handwritten records and doctors' charts and in hospital records. So, for the most part, people have adapted to it, but with the changing EMR systems, it's very important that people are trained on it, that they constantly relearn, refresh their knowledge base, make sure they're understanding what their EMR system is. People change institutions, so they may go to an institution that uses a different system, so they really have to become adept at entering information into the EMR on a daily basis with each patient interaction, because what you record is really important, not only to you, but to your colleagues who come an hour after you, a week after you, or potentially years after you. And what you write down gives direction, gives context, and obviously, diagnoses, plans, treatment plans, and everything that goes on with the care of the patient in totality. So we're talking about that. I'm just talking from the liability perspective. I know the other speakers here will add their point, but I just want to say that it's really important that, new doctors get trained on this. The doctors who are familiar with their systems collaborate, teach, talk about what works for them. Shortcuts and cutting and pasting does not work. There are no shortcuts to good record keeping. If there's information to be imparted on the medical chart that drives care, that drives diagnoses, that reflects on your differential diagnoses, you have to put it down. If you don't put it down, it's going to be very hard 2-3 years later if unfortunately you're involved in medical litigation and you don't remember and you're relying more on your custom and practice, which could be developed, could be very good, but having it there in real time when it occurs is very helpful and essential in the record. And it's very helpful to us as the attorneys if we have to defend you in a medical action. So there's more I will say, but I want to give everybody else a chance to talk.
You want to make any comment about that better documentation?
It's, one, I want to agree 100% with our esteemed attorney here. But, I've been in practice for a couple of decades now, and I can tell you 2 real short, quick stories. I was working for a managed care company as well as having my own private practice. One office I went into, physicians was a gray-haired guy. I can kind of identify with it now, but back then I actually had a full head of hair like Soleus, and it was dark. So what was interesting to me was I had to do a chart review. So he walked up to a box and pulled out a stack of cards, 3.5 by 5, and essentially was the date and the charge. And usually there was a word that meant a diagnosis of a chief complaint. So on a 1 3.5 by card, by 5 card, he was able to get maybe 20 visits. It was a very efficient way of doing things from his point of view, I suppose. Another physician, neurologist, just impressed me to no end. So I'm an intern doing rounds in the hospital, and I'm following him around like the rest of the young puppies And when watching him do amazing exams and asking questions and all pitching in, and then he stepped out and whipped out a little micro recorder and dictated a beautiful note. Now, you have to be into medicine to really think of a note being beautiful. But it was like music, think of it as music. It had all the right notes, right? And it worked together. And somehow he remembered what we did during a 20-minute exam and was able to document it. He had someone, obviously, who could do a voice-to-text printing, right? Well, we have that now. So I think to your point, sir, is we do have voice-to-text. You should take advantage of it. We can't telegraph our notes. You can be very, very thorough now. And there's an opportunity, depending on how the EHR is structured, to do some point and clicks. That's not the worst thing in the world. When I got my EHR, I invested a lot of time, and we're going to talk about investments later on, but invested a lot of time at the front end creating these templates for myself for common things, because common things happen commonly. So why not have the outlines put in there? And then just clicking and subtracting as needed got me to put a lot of information. Again, when I started this 35 years ago, and the EHR 15 years ago, there was no voice to text. I had to work smarter and harder. So definitely document as much as you can, because as our attorney said, you're not just documenting for yourself. You're documenting for whoever's going to take care of this person X number of days or weeks. We might be referring this person to a subspecialist. So don't you want that subspecialist to get a nice package wrapped in a bow with a very thorough history and physical, so she doesn't have to repeat all the same questions? And then if it's within the statute of limitations of 2.5 or 3.5, 2.5 years from now, and there is some litigation that may be occurring, well, your attorney is going to have to refer to this record. And you could say, well, I usually do this. And then you got to hope that a jury believes that you usually do this. And it's going to be hard to defend that you didn't document anything in 2024, when I just said there's voice-to-text capability. So then what's your excuse for not doing it?
Well, yeah, one thing I always teach when I do in-service to our new nurses or even residents, just read back your note. When you write your note, read it back to yourself out loud. Does it make sense? Read it again. Make sure things are spelled correctly. Think of it as if you're writing a little essay or a short novel, what have you. Not just from a legal perspective, though, from a patient safety perspective, good documentation sets the tone for the continuity of care that you kind of just touched on. When that consult comes to see your patient, right, you want that consult to be able to see everything that was done before, that consult came to see the patient. So it's really about setting up that note for the next provider who comes to see that patient.
Second topic is EMR. In my opinion, EMR is the best thing that happened in medicine in the last 10 years. We use it on daily basis and save us a lot of time. It also decreases the risk of discussion error, and most of us use template or use copy and paste, especially if the patient has no symptoms. We just copy and paste the symptoms, and normally we can this complaint. So what are the risks associated with overuse copy and paste in the
I'll touch on that. It's not going away, right? As much as defense counsel, we want to say stop copying and pasting, don't use template notes. It's not going away because Epic and other EMRs make it so easy for you to use. And when you have a floor with 30, 40 patients and everyone's short-staffed and there's 2 attendings covering that floor, the providers and the residents, they're going to use that functionality. So it's really about learning the proper ways to use the copy and paste function, right? If you use it, read it back. Does that lab result still make sense? Or am I pulling over results from the prior day or the prior week, right? You really have to be aware, not just bring over information without double checking that information.
And I would just add from the legal perspective that, and what Noah says is absolutely true. I mean, when you're seeing 30, 40 patients on a busy floor it is extremely time demanding and extremely challenging. But, relying on just, cutting and pasting without checking what you wrote, where you're bringing up stale information or information that has evolved, that's dangerous. It looks like you haven't seen the patient, you're not spending the time necessary, you're not reviewing the symptoms, you're not discussing the new lab results. And, if you are, involved in a medical malpractice action for, omissions or commissions in your care, that will come back to, bite you. So, yes, there are times cutting and pasting function can be valuable if the information has not changed and remains consistent, but the duty is incumbent upon you to know, to evaluate, to, speak to the team what has changed, from simple as vital signs to lab results that were pending, because you don't want 3 days of admission to have the same note again and again when things have changed. That will look bad. It looks like the care is not being delivered. It looks like people are not seeing this patient. And then if something really does happen, some sentinel event, some crisis, the records are not going to reflect that there were these important changes in what was going on. So cutting and pasting, is going to happen in the right sense. It can happen on consistent issues, but you have to be very careful when you do it, and you have to talk to. One thing what Noah was saying with the younger physicians coming in, if any of you are working with interns or new residents, that they understand these pitfalls. And, it's important that, more seasoned professionals within the medical profession teach. I mean, I think one of the things all the doctors here know is teaching is vital to the, continuation of your profession and getting new people, to be good providers.
Sure. I'm going to some seminars on malpractice and actually participating and so on. And you'd be surprised, and it goes to Noah's point and Jonathan's point, how many medical records roll over a history of present illness of something that happened 3 years earlier, and it just keeps rolling, visit after visit after visit after visit. And the reviewer system is not consistent either with the history, not consistent with the physical exam, and you have to wonder what's going on. And I think people are racing to document as much as they can to try and do the best they can. But to Noah's point, you've got to review your record. You're just signing this. And you have to hope. If you're in solo practice, like I was, now I'm sort of more of a telemedicine kind of guy, but in solo practice, you earn what you do. And I always worked a side job, I'll be honest with you, because to do really complete primary care was not the most financial feasible thing. So the time I spent to review my notes and make sure I didn't make errors, I had to make up with being like a part-time medical director somewhere. But again, one of the problems to your point from a patient safety point of view, if you're rolling things over for literally months and years, how do you know what's going on with this patient when something untoward occurs? Now there's nothing. You could have had a font of information that would have guided the providers. The other thing, especially if you're in a teaching environment, you got to look for consistency, right? So if I got a patient who was seen today by a medical student, then a resident, and there are nurses' notes, they're actually nurses' notes. Did you know that nurses wrote notes in hospital? Most doctors should know that. But you'd be surprised at the inconsistencies that will suddenly start popping up. So you want to, especially if you're in a teaching environment, you want to get back to the medical student resident and say, why did you say A when I believe it's B? Maybe I'm wrong, maybe it is A. But do not leave the inconsistencies in there unaddressed. Explain why there was an inconsistency. Maybe there was a difference at 10 a.m. versus 3 p.m. when you saw the patient. But do not leave them unaddressed. You don't erase, you don't delete, because there's this magical fairy dust or an audit trail. So they'll know that you were trying to change things. There's no need to do that. There's no shame in making a mistake. There's no embarrassment. Acknowledge that something is different and explain it.
How can aging reports for diagnostic tests help protect against liability?
I'll go first?
Yeah, the first.
Yeah, so the technical part of healthcare is very close to my heart. One of my friends and mentors, Frantis, here is from HIMSS. And they're a big health information management system society organization, and the focus is on how to apply technology to provide the best healthcare possible. And the aging reports, essentially what it says is all the EHRs, as far as I know, it might be someone that made one in a garage, but all the EHRs essentially create, think of this as an audit trail. So if on September 26th, I order a chest x-ray on John Smith for diagnosis follow-up on pneumonia, the system is going to date and time it, and then it falls into, let's say, a calendar. And then all I have to do is have someone, they don't have to have a master's degree, you don't even need a college degree. Someone who knows how to press a button that says, tell me all the things that are due this month. So what you do is when you order a blood test, when you order a diagnostic imaging, maybe when you order or recommend a referral to some specialist, generally will fall within, say, a 30-day time frame. The computer will then give you a report and say, I did not get a chest x-ray report back, I did not get a leg report back, but I did get the consultation report back. And on the two things that are missing, it is then incumbent on the practice to reach out to the patient. Did you go for the chest x-ray? Did you go for the blood test? It's either yes or no. If it's yes, don't be surprised that you didn't get the report. Sometimes that happens. Person went, followed your advice, and is waiting patiently for you to call them back, but you never got the report for whatever reason. So aging reports help you from a liability point of view, because maybe while you were following this person's pneumonia, the radiologist says there is a new nodule that wasn't present 3 to 4 years ago. Well, if you don't follow up on that chest x-ray, that new nodule is going to become a bigger nodule 6 to 12 months later, when maybe the person gets other signs and symptoms of maybe an obstructive pneumonia, and you have to say, oh, I'm doing a chest x-ray. And now the 2 centimeter parabronchial lesion became a 4 centimeter parabronchial lesion. So, and then also it labs. So the whole thing is, if you ordered it, you thought it was important to do, right? The attorneys, I'm sure, will riff on this. But, you know, if you ordered it, the jury's going to ask, why didn't you follow it up? And you can't say, I expected the patient to do it and they didn't do it. You cannot aggregate the responsibility. The computer system makes it impossible for you to follow it up.
And I would just add to that, to know if it wasn't followed up, because you can check it in real time in the computer system. So I just want to add, because I think those are, you know, great points, that, you know, in terms of the training and staying current with, you know, EMR and EHR systems, you know, we've seen obviously since the pandemic a lot of turnover in the medical field, which has been, you know, a big challenge, and a lot of people came into the field, have left the field, you know, even now after COVID. So people need to be retraining. They have to know the systems they're using. They have to understand, you know, the pitfalls, the little tricks that may be specific to a different EMR, and make sure that the people that they're working on with in the hospital or even in office-based systems are trained appropriately. So that's really important, and that's, you know, often incumbent on, you know, practice group leaders and division and department chairs and people really making sure that there's a robust system of training and education and re-education. So it sounds, you know, obvious, but I think, you know, in the past few years, especially since 2020, it's become even harder because there's been so much turnover. There's a lot of turnover, we know, in nursing. It's been harder to attract certain people, certain specialties. I know, you know, we've read in obstetrics and pediatrics, you know, there's a crisis in attracting people right now in the medical schools. Unfortunately, that may continue in the years ahead. So, you know, training is ever more important, and it's ever more important on this issue that we're talking about with medical records. I just wanted to add one other thing, Doctor. I know we have a few more topics that we definitely want to get to, and any questions is, you know, the audit trails, because that's one of the topics here, which we on the legal side see, and that's an important topic to talk about. And that's, you know, the audit trails and the data that attaches to the medical records electronically for the life of the chart and beyond, basically forever, on the records that are kept in terms of each and every entry that's put in the chart. And that's, you know, both, you know, a blessing and a curse with the medical records, that whatever you write down is there, you know, basically forever. Well, the, you know, the plaintiffs bar that we deal with and our adversaries in these cases have, you know, become smart about this. They realize, and they think, sometimes correctly, oftentimes incorrectly, that there's this treasure trove of data that will show things were not recorded timely, that they were recorded improperly, that they weren't recorded by the right people. And we've spent a lot of time in recent years understanding what the metadata is, what the audit trails show, and often it shows who entered information, when it was entered, who was entered by, to the second. So this is a big area of litigation now. There are some recent cases in the New York courts that have been more protective with the production of some of this information, and obviously we push back on providing a lot of this information because it's quite onerous and very time-consuming for the hospital systems to dig into this information. And we even know on a basic 3-day hospital admission, the EMR could be thousands of pages with all the repeats and the way it prints out and the way it looks on the screen. You go into the metadata, it's equally, if not sometimes much bigger. So, plaintiff's bar thinks it's easy, you just print a button and it comes right out of the system. That's not true. It takes a lot of time and energy by human beings to often retrieve this information. So I just would say this, and we could spend a whole evening talking about audit trails and metadata, that it's evolving in the courts. The defense bar is pushing back on this. The judges are beginning to understand what's involved here, but it's our job as a community to educate the courts and educate everybody what's there, and the hospital systems people are understanding that this is an unfortunate but necessary part of our litigation world now. So I just want to bring that to your attention. Many of you as providers won't have to deal with this on your day-to-day, but you're definitely going to hear about it. So I just want to give a little intro and context to that.
Thank you. I'm James Neisel. I'm CEO of Etna Group of New York and Zion Clinical Documentation. So the airline industry used to have the best safety record before the doors blew off in Wall Street, and they had the black box recorder. So you could go back and I make the analogy that with malpractice cases, you'd like to go back and be there, right? It can't be unbelievable if you could replay what happened. So with the documentation going on now with the AI, of recording the interview patient and explaining the lab tests without nothing. Thinking your differential is actually recorded, but the EHR note is actually extracted from that. And it's about 95% accurate in both the doctors. Make it perfect, or the humans put in the loop. But we actually have the actual recording of the voice and discussion. And we saved that. It's not terribly expensive for 2.5 years. What do you think about that idea?
I mean, that's the future for sure. I mean, I think if it's happening now, it's going to be ever more prevalent in the years and decades ahead. I certainly want to know more about the accuracy of the recording. Obviously have people listen to it. I think it would be helpful as a teaching tool if that system, is and becomes widespread for people to hear themselves and hear if it's consistent with what they're doing and what they want to do and what they should be doing within the standard of care. But I'm curious what you think, Doctor, about AI and if that's impacting your practice now. But we know that's become a big part of how people are going to practice across the world, and certainly here in New York, the use of artificial intelligence that's going to generate, notes, going to drive a certain direction in care recommendations and in testing and things that are done. So I mean, the fact is, if more things are recorded, it can be protective in the litigation world. But we want to know how consistent it is, how accurate it is. Does it capture everything? You always hear with recordings, are there outtakes? Are there things that aren't kept? Does it have things that trail afterward? When you have photographs or videos. I want to know more about the technology. And I think some medical providers maybe perhaps would not, initially welcome with open arms the idea that everything they're doing through the EMR is being recorded. But that is the future. You're right. I mean, it is going to happen, and I think that's we have to be prepared for that. So.
One place where I'm seeing AI used with the EMRs, some EMRs actually have functions now that you can turn on the AI systems, and they're actually really good predictors of, for example, sepsis when a patient presents to an ED. You could turn on functionality and AI can predict whether that patient's in septic shock. So, I mean, I think there's really good use cases for AI. Your particular example, I definitely want to learn a little bit more about that.
Sure.
Hi, my name is Steve Bradford. I'm a CEO of Monsignor Care to help hospitals reduce readmissions among the geriatric population, which Dr. Volpe introduced earlier today. My question in relation to cybersecurity. So we know that cybersecurity breaches are becoming much more prevalent within hospital systems, and that leads to lack of access to technologies that clinicians are accustomed to using, which can lead to mistakes and things like prescription dosages or a myriad of problems. In a world where it's a matter of when and not if a cybersecurity attack is going to happen, how does a hospital protect itself?
Well, I could tell you that CMS and DOH are definitely cracking down on cybersecurity protections and regulations. I think one thing that you could look at is your third-party vendors that you work with in your institution, making sure they're properly risk assessed before they're onboarded, right? That's one way. How are they handling your data? Is your data encrypted? Do you have this as terms and conditions in your contracts with your vendors? There are software platforms out there that kind of automate this process for you. And actually a lot of healthcare organizations are moving towards implementing third-party risk programs to comply with some of these new regulations that are coming down the pipeline. That's one area I can see it, but you're right, it is a question of when and not if.
Thank you. Hi, good evening. Charles Presto, I'm a internal medicine hospitals in New York, Presbyterian, Queens, also a media past president at the Preventive Society County of Queens. My question is about audit trails. And I've heard different things from different people about sort of the extras in EMRs. So I use Epic at New York, Presbyterian, Queens, and we have different places that are not strictly documentation. Like well, there's subscription is one. Another is in the quote-unquote handoff section. Another is in the hospital course section. And each institution sort of has this culture around how we do a handoff. And I'm actually doing one right now. I'm ending my clinical shift, and I'm a colleague who's going to pick it up tomorrow. And I have to communicate somehow to him or her or they of what they should be aware of for the state. Not only clinical information, but also sometimes non-clinical information. Like, so-and-so's aunt is the healthcare proxy, and she's a pain in the butt, and she's going to request you to call 3 times a day and be aware of that, or something of that nature, where you wouldn't necessarily want it documented in the medical record, but you want to give your colleague a heads up for something like that, or whatever. I'm interested in discoverability of these types of things, and if there is litigation, what of those types of things are discoverable and under what circumstances?
So, I mean, you said a few different things there, right? So that example you gave about the healthcare proxy, you might want to document that in the record, right?
You have to.
Yeah, I think you have to. Be objective.
Well, that, we can talk about that.
And then, you also have to understand that the medical record is the patient's record, right? So anything that is in there, it's owned by the hospital, but it's the patient's medical record. So if you're using something like Secure Chat, which is very popular and it's a very big topic amongst, the hospitals now, that's technically not part of the record. And as an example, I've seen full-blown consults occur on Secure Chat, right? So the consult never even saw the patient. They're just talking with the team, all on Secure Chat. The question of discoverability, I think, is interesting. I think it's going to come, in my opinion. Does the audit trail capture something like Secure Chat? I think it captures times it was sent, but it might not capture the body of what was said. but I don't know if you want to add to that.
Yeah, I mean, you know, the prevalence of secure chat, I mean, I've heard about it obviously with, you know, a lot of the doctors who are coming out of medical school, they're very comfortable with it, they are using it, it can be a great service, but you have to assume that eventually, you know, as now it's become more widespread, you know, the plaintiff's bar in medical litigation is aware of it. They're going to ask for it. You know, what you said before, you know, denigrating a patient or a family is always, you know, dangerous in any part, and people should, you know, obviously be trained not to do that. But at the same point, if you know, there are words to be used that aren't necessarily denigrating, but kind of give background and information that will give guidance to the care team that comes after, I think it's important to capture in the record some of the stuff that goes on secure chat that will drive care, and that the team, beyond maybe the two doctors who are communicating on secure chat, will have an opportunity to see. I mean, I think one of the problems, there's again, you know, a bonus, that, you know, boon and a, you know, bane of all this is that it really helps. You're doing a handoff, it's there, you're doing it in real time, it's quick, people can see what's going on, you're giving information on the patient, the family, what to look for. Some of that important stuff, you know, should not just be in secure chat. And I think we've seen where people neglect, unfortunately, to put it into the record, and that's a problem. I think, you know, with audit trails, you know, some of the stuff, you know, will be seen, or they'll see that there's other communications, or there are communications at certain timestamps with some of the systems that, you know, the plaintiff's bar will dig to try to get. So you want to be careful. I mean, if we make the argument like Noah said, that's not part of the patient's chart, you know, there'll be pushback. What is it then? You know, are these communications are part of the care? So this is definitely, I mean, you hit the nail on the head. This is a big part of where we are now with medical records, with AI, with communications. I mean, it's all part of a piece. But I think it's really important to understand that if something's really important to the care team, important to that handoff on what's going to happen in the next hour, or the next 12 hours, the life of the admission, whatever that is, that it's in the chart. And people also, again, what I was going back to is if there are quotes, and I was going to say this earlier, because if you have a sense that something's gone south, or is about to go south, or you have a challenging family that, you know, are difficult to communicate with, you know, you have to be careful on what you write, how you write it. You don't want to malign or denigrate them in the body of the chart. And we, you know, we've all seen crazy things where some very unfortunate things have been said by different people on the care team. But you do want to, if there's a quote about something that they say, the denial of a needed test, someone who's, you know, AMA, you know, that should go in the chart. If there's something, because 3 years later, as we've said here already, there's not going to be a memory. You could say, oh, I remember at the time the patient was very volatile and combative, but maybe they said something that indicated that. So that should just go in secure chat. It should go in the record, and people have to be good at writing the narrative. So I think you should assume that everything you write could possibly be discoverable. And I think, unfortunately, in New York, we could talk about this at length, you know, the courts are looking deeper at this. There's been some, you know, adverse rulings on certain things that have been provided. If we have time, we'll talk more about, you know, quality assurance issues and where the courts are kind of in flux on that. But we're definitely at a time, you know, where the courts are digging into this. The judges are, as we said, starting to learn. You know, they need to be educated even more about a lot of the electronic information. But you should assume when you're doing what you're writing that there's a definite chance it could be discoverable. So that's my, you know, cautionary advice here.
Dr. Volpe, you want to make a comment?
Yes, first on yours, sir, and yes, ma'am. One, I think my take-home lesson from listening is secure chat should just be a distillation of what's in the record. It shouldn't be anything new. If it ain't in the record, it shouldn't be in your secure chat. Why? Because if we're going to say that secure chat is not something that's discoverable, then potentially you're putting medical information that's pertinent to the management of this case in a place where no one can see. So it's all about training and habits, right? I remember again, 1.5 million years ago in a previous century, we used to do is we would have a shorthand sign-out sheet. And I've seen them appear inside EHRs. And some very simple, and these are like the 5 things that we always want to make sure we share with the next person coming in. And then there's always room for comments. And that's, if you want to put that in a secure chat, that's great, because imaging is fast. But again, it should be a distillation of the record, nothing new. As far as cybersecurity, I can be wrong because I'm just a doctor. Just a doctor. But what I vaguely recall is that most cybersecurity failures are not related to how expensive your software was or how cool your hardware was. It had to do with you getting an email from your executive director asking you to please, this is very urgent, I'm in a meeting right now, and I need ABC sent to me like 5 minutes ago. And don't disappoint me. And that is a very common way of looping people. If you get one of those, you must do now emails, just like they do in surgery, time out. There's no one in front of me that needs CPR, which is something close to my heart, pun intended. And say, why would they be sending it to me so urgently? Maybe I should call my exec and see what's going on. Is this legit? Look at the time it came in. Sometimes it's like at 4 o'clock in the morning, which is a time zone that's probably not associated with where you work, but probably someplace else. So human failure is the greatest source for most cybersecurity threats. And there are many great programs out there. I'm not going to mention any by name, but there are some very good programs out there, and I participate in them because of the different jobs I do outside being a solo practice doc. And they're very good, and they're very short exercises. They're 5 to maybe 20 minutes long. Any company, reasonable size, and we put that reasonable sizes, because if you get hacked, you got to decide, was it worth not getting that, paying whatever, $150 to $300 a year for cybersecurity training for my staff, versus shutting down my operation and having to report to my clients that their tax ID numbers and a lot of confidential information just went out the window. So I don't know if I answered your question completely, but again, human failure, biggest thing. And then to your point, Microsoft and some of these other companies, I'm not to mention them because they provide the operating system for most of the software that we use, they're monitoring stuff too. It's just how soon do they release that information? But they are looking and they say, oh my God, X number of hospitals have just recently been hacked through this sort of Trojan software. But how did the Trojan software get inside the hospital system? Is how you must answer this question in 3 minutes or you will be fired. Yes, sir, yes, sir, yes, sir. Please add the 2 attachments with the staff list. And then also, be careful what you're putting in your social media, right? Because you're creating a profile. It's very common for these individuals you get a phone call and, oh, you know what? I heard you're working for company A, and it's so good and I've been seeing what you've been posting about it. And I just need to know which guy can I call in this particular department? Could you give me his phone number? So again, human failure, probably one of the greatest sources of failure for cyber.
I'm Alex McGrath, Chief Information Security Officer. You kind of threw me off a little bit. I was telling you the best position against us.
Thank you, sir. Thank you.
Literally. So my question is more on the legal side. Here? Sorry. My question is more on the legal side. The hospital says they have legal teams protecting them from cybersecurity related threats and all that. Everything's cybersecurity sucks. For private practices, do you think that they can get away with states with non-hospital groups and not doing security literacy and not doing this at a minimum a risk assessment which incorporates some sort of security awareness, or would that maybe in certain cases be okay with this circumstance?
In 2024, I think it's incumbent and necessary for everybody across the board, because as you said, it's not when it's not if, it's when, there's so much information and training out there, both online and in person. So I think everyone's expected to be up to speed on these issues, know about them, protect themselves, buy the appropriate protections. Because once it happens and start to Volpe said, there are protections for small office practices that are not that expensive. But, if you don't have it and you could have had it, and then some hack happened and information was, released or stolen, you're going to be on the hook. The other thing I would say, and Noah kind of touched on this, is, having, contracts, know who you're sharing information with, and also, very vitally, right now, a huge growth industry is cybersecurity insurance. All the major hospital systems across the United States have it. I think, there are policies that are available to, small independent providers that are not that, expensive in the realm of things, because, when you look at what could happen, it could be, very, detrimental and debilitating and destructive to the practice and to many areas of what people are doing. So, I'm not here as an insurance salesman by any means, but I think anybody, whether your practice is, one physician or 10 physicians or, 100 physicians, look into that. Speak to your insurance broker, make sure you're protected. There are numerous products out there, and with those products, there's a lot of support. One of the things with insurance, which is very good in this, current environment, is you get training. You get an attorney who comes in. If unfortunately some hack happens, you get a reaction team that reacts within, if not minutes, hours to protect you. So that goes for your, what you're paying. So you're not having that and keeping your head in the sand, whether you're just one doctor here on Queens Boulevard. At the very least in this environment, it's incumbent even on that one doctor to speak to his insurance broker who helped him maybe get his medical malpractice, his lease, his information. And if that person doesn't know, direct them to somebody and say, I'm a solo practitioner here in Queens. What kind of products are available to me? What kind of training is available to me? I know this is out there. I'm interested in it. What kind of cost are we talking about? But it's a huge growth area. It's everywhere. So again, what I'm saying is if you don't do it, ignorance and just kind of shrugging your shoulders and say, I don't have to worry about it, is not going to be a good defense if something goes awry.
That's kind of why I was curious. You trust separations in any way, conflict of interest, but they also make me think which the first place is over protecting your assets, right? Respond.
So I'm going to fish for another compliment from you if it's possible. So one of the things my experience solo practice taught, right? So there's cybersecurity, but I believe that there are levels of cybersecurity, right? There's something called high trust, and then something else. So if I'm an enterprise hospital system, then I gotta be very high trust, right? But a solo practice provider probably is not high trust. I mean, they're going to be something less than that, but adequate. So my experience is either through the insurance company, like the example I'll give you is your homeowner's insurance, right? So they may come to your home once a year, every 2 years, do an inspection and say, you know what, I think you need new appliances. Those appliances are dangerous, blah, 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 blah. They have a vested interest in giving you that good advice because they don't want to pay for a bad outcome associated with that thing. So the insurance company might give you some information, even if it's a checklist. Back in when I started, again, previous century, no gray hair, it was, I had a medical, what do I call it, a billing system with an appointment calendar in it. And so when I sent my billing to the clearinghouse, it went through like a beep, beep, boop, boop, pop, pop sort of thing. It was like a modified, think of it as a modem, right? Almost fax, so simple. It was pretty secure. And not too many people were hacking into it at the time. But now everything is on the web, right? So things that go between you and that web are sources of risk. So again, who's going to tell you about that? Well, the insurance company might tell you, and if you might want to hire an IT company. Again, 30 years ago, hey, I can cobble this together in my garage. Now you need an IT specialist because that specialist might tell you, that really cool router that you got on something day in October from the world's largest email vendor, you did not update the security definitions in it for the past 12 months. You have now put your entire network at risk. So just as we believe our patients, when they come to us, pay us through the insurance carrier and their co-pays for our judgment, we have to feel comfortable to pay another expert to do the same thing, because the risks are just too high, not just for you, but all your patients have all their private information put out there.
All right, thank you.
Did you see that physicians could get sued because of their staff errors? And how can we learn our staff to help us with our EMR and to avoid any errors to really affect us? Learning our staff.
Well,
Front, the back.
Well, I mean, the issue of training staff is, obviously ongoing and absolutely essential to, the health of a healthcare organization, the continuity of capable professionals and new generation of professionals. So, I think, as I said, right now in 2024, it's been a challenge with the turnover and the difficulty of attracting certain people to certain specialties, which may be, with us for several years ahead, unfortunately. So, we have to, look at that turnover, look at the people coming into the profession, and really every organization and every provider works with other people, whether it's a nurse, whether it's interns, residents, other allied medical professionals, are their training procedures, up to date, not just with EMR, but with all delivery care systems. A defense of just saying we had a lot of turnover is not a defense. If care is not being provided to standards. So you have to be aware of these challenges. Recruitment is hard. And as people come in and people leave, I think the biggest thing is making sure the new people are properly, trained. So I think it's very important in the organization to look, almost yearly on, are there systems for training up to snuff? Are they timely? Like Dr. Volpe just said, do they have the, with technology, do they have the latest information to provide to all their providers? I mean, we all here in Queens, there's some huge medical systems here with, hundreds, if not thousands of employees, all cogs in an important machine delivering care to human beings daily, saving lives. What are the training systems on from the person, the lowest person on the totem pole to the highest person? Are they collaborating? Are they talking? I mean, these are big, giant issues, but to ignore them and not to deal with it, especially again, and I keep going back to this because we're seeing that the turnover that's out there is profound at times, but what are you doing about it? So, a lot of this takes extra time. I think in the medical profession, it's always been part of the profession to train and teach those who come, after you, and to make sure that, there are capable people to, take the reins when you retire. So, we really have to work even harder than ever on that. It's another, challenge in this medical world now is, what are our training systems? Are they being reevaluated? Are they current with what's needed from cybersecurity to any developments out there? Equipment is expensive, testing equipment is expensive, everything's expensive. There's a lot of budgetary concerns. I mean, one other thing I would just say from the issue of, enterprise risk management, I think more and more the trend is to include everybody, not just have an isolated C-suite, but the C-suite has to collaborate with the medical staff. They have to collaborate with the medical directors. People have to know what people are doing. So this is the world we're in now. You can't have that isolated C-suite on the 23rd floor not talking to, the medical providers. Maybe that worked 25 years ago. It's not working so well now. And I think, that's the challenge, I'd say, in this decade and going forward.
Yeah, that's exactly what I wanted to say. I always say to my staff and other risk managers, it has to start at the top. You have to have buy-in from the C-suite, from your chief nursing officer, from your chief medical officer, because when you have that turnover and you have new staff coming in, they're coming into a culture that knows that, okay, we have to report these errors, we have to document this. They're coming into that culture of safety already, right? So we should be training new staff, of course, through orientation and, utilizing the legal aspects of the importance of documentation, but setting forth that culture really starts from the top.
I'll try and be quick with this one. When I was in practice, the majority of providers were independent docs. Independent physicians are now in the minority, ever shrinking minority. part of it just has to do with the cost of doing business. It may not be fair, it's just a reality. You know, the days of the 3.5 by 5 index cards are all gone. There is a cost to providing care. As we move towards a value-based payment model, there are opportunities for smaller practices to actually earn enough money to cover these things. Between fee-for-service now and value-based payment somewhere in the future, maybe 6 months, 30 months from now, there are opportunities by joining IPAs, by joining ACOs, and who may subcontract to a management services organization, so all these 3-letter acronyms. The point I want to make is you can leverage the strength of 10 to 150 practices so that you can afford to have maybe not high trust, but a pretty good trust, right? And you may not be able to afford the most expensive Wi-Fi router, but something that's very secure and pay for the updates. So I want to give hope. You know, like we can kind of talk about the costs, and I'm listening as a doctor, it sounds pretty depressing. But I just want to remind everyone there are opportunities out there again for the IPAs and ACOs to join together. You can still be an independent provider, but leveraging each other, you can then buy into a contract with an organization that can provide you the kind of service that your patients deserve, that you deserve, and will keep you, again, I won't say completely out of litigation, but decrease the risk of litigation and improve the kind of care you can deliver.
Oh, so,
Yeah, I think.
sure. Next slide, please. So the next topic about communication barrier. So all of us, we get a normal result. We ask the patient to come for follow-up, they never show up. Abnormal mammogram, abnormal CAT scan, we call them, and we went on documentation, but they don't come back. We call a few times. So the question is how to document this to protect ourselves in case patients show up after 1 or 2 years with cancer. Do we have to send them like certified letter?
Maybe, right? The question of is it enough is oftentimes up to the jury of your peers to decide a question of fact, such as that. If you have a Spanish-speaking patient, is it enough for an English-speaking patient to call and leave a voicemail? Probably not. Definitely not, actually, safe to say. So the question of what steps do I need to take for a no-show patient, I think could vary. I think the important takeaway here is that the healthcare organization has a system in place to cover issues such as these, right? So if an automatic letter goes out, and then we're documenting that. A process that all the providers will be able to follow, I think, is the important piece here.
And I would just add, I mean, here we are in New York where people speak, dozens, hundreds of different languages. It is a challenge for institutions to make sure that there is no communication barrier to the provision of good care, that patients and their family members understand the care that's being provided, the communications about that care. And at this day and age, it's really important that the systems are in place and people are trained on them to make sure those interpretive systems, I know, for the very, very most part, it's electronic and you can get access to that, but having a shortage of access to that information, having significant delays in access to that information is not an excuse. I mean, you have to know that there are going to be language barriers between provider and patients and their families, and it's really important that things are explained. They're explained carefully, whether it's informed consent, whether it's referral, and it's documented. And I've seen that because I've been, all of us here, have been on the other side, being, providers, you've been patients, your families have been patients, and you've seen, the frustrations with communication And it's really important that those systems, and I think, you know, they could be improved, and hopefully in the years ahead, they will be improved. You know, in a busy hospital, in a busy ER, you know, sometimes things unfortunately are lost when there are communication barriers. And I think that's another thing that, you know, needs to be stressed and needs to be trained on, and make sure that those technological systems are improved upon, that they're in place, and that nobody should, you know, not be able to get the care they need and communication by their care because there's not somebody who speaks their language, there's not a system that can provide information in that language, especially in a place like New York where we know there's huge, you know, diversity and variety of you know, different speakers. So it's really an important issue, very important.
I agree with everything that was said. One of the things that I would emphasize is that when you first meet that patient, and maybe subsequent thereafter, you want to document the level of what's called healthcare literacy. What do they understand about health? So we need to document their preferred language. We need to document what we're doing to meet that need for the preferred language. We should probably document what we're doing to address the level of healthcare literacy. We shouldn't just shrug our shoulders and say, they don't understand COPD. I'm just going to use the word COPD. No, you're going to have to come up with a different way of explaining it. So you want to document the preferred language, what you're doing to meet that preferred language, what you're doing to address healthcare literacy, the level of healthcare literacy. As far as no-shows, remember we talked about the value of the insurance company? Well, unless you're in Florida, almost everyone I can think of here in New York has med-mal insurance. And so if you've got med-mal insurance, they're a great resource to ask, because remember, they're going to have to defend you when the patient who didn't go for the test, when the patient who didn't come in for the follow-up, ultimately, unfortunately, has a poor outcome, which could lead to litigation. And so you don't want your insurance company to educate you on the best way to follow up with patients in the courtroom, right? You want that in the beginning. And when I first got med-mal coverage, I was calling them about every stupid thing. Oh my God, my paperclip fell on the floor. Is that a problem? I don't know. And so don't worry, we'll open up a folder. We hope you find your paperclip. So one of the things that they'll teach you from the insurance companies, there is no wrong answer, there's no wrong question, no stupid question, and there's no bad reason to call them for advice. Call them for advice. Most of us are paying anywhere from $25,000 to $55,000 a year if we're just plain non-interventional type folk. And then if you're OBGYN, we're in the $250,000 to almost $500,000, and then if you're a neurosurgeon, it's like $1 million. So you're paying a premium, take advantage of the experts, ask them for help.
Thank you. Next slide again. A question?
I don't know who the microphone. It's fine. Sorry. I don't know the microphone. I'm just in.
Who are you?
My name is Attia-Alla. I'm a provider of practice outpatient neurology and physician assistant. Along with I just announced on with the endovascular and surgery department. I actually have two questions. One from a clinical provider perspective and one from a patient perspective. One question was the handoff assignments when it comes to the in-house, which is the inpatient setting, as opposed to doing the outpatient setting within the hospital setting when it comes to handoffs. The question I had was, when you're practicing outpatient, the outpatient practice for using the EPIC system at Mount Sinai. In the outpatient setting, it's a little bit different. We have a census that we sign off at the end of the day to your team. In the outpatient setting, we're doing the multiple questions within the big system, the nursing staff, for example, when it comes to the handoff. How does that affect it from a litigation perspective as far as how detailed those that communication was to be on an outpatient basis as opposed to that handoff that you're doing on an inpatient basis within a hospital setting?
Well, I mean, we did touch on this in terms of, the secure chat and all this, and I think what Dr. Volpe said is really, echoes very truly on making sure that what's in there aligns with what the care is. Handoffs are vital, and, poorly done handoffs often lead to, obvious complications, poor communication, and poor follow-up or no follow-up, leading to, problems that can result in litigation. So I think it's really important that those things are discussed, get in the chart. From a litigation perspective, I go back to the handoffs. When they're not done well and they're not recorded well on what's pertinent, when the 12, to 8 shift leaves and the new shift comes on in the morning, whether you're waiting for a test to come back, has it come back, how long has it been come back, is the patient, need to be cleared for some intervention, a surgery, or some other procedure that needs to be done then? Does it need to be done that morning? Can it wait? What's the communication with the family? Are they aware? What are the, issues with any, informed consent? There's so many things that have to be checked off that maybe on one shift are still lingering and we're not able to be checked off. So it's really important that those are done, and it's hard because there's a lot of handoffs. It's not just one patient. You have a lot of patients on a unit, depending, like with your specialty, it's, very demanding, very, high intensity, and then you're dealing with some, acute patients all the time. But, recording that, documenting that, having a system in place that does not just get stuck in a secure chat, as we've talked about, is really important that it's clear in the chart. And that's a skill. I mean, that's something you can keep getting better on and talking to your team, is how are we documenting these handoffs? What are we emphasizing that's going to be important to the next shift? What are we missing? And I think that sometimes take review. What could be done better? You want to head off those problems before they occur, and that's the constant teaching, education, re-education, and thoughtfulness that, goes with the job. It's, part of what you need to do to be a good provider. And those are just tools, I'm saying, that will minimize the risk of litigation. There's no, magic pill that will, prevent anything. But, I think tonight, touching on the secure chat, touching on the handoffs, touching what really necessarily has to get into the chart for your direction, the continuity of care, and then for the immediate and ongoing subsequent teams is really important. That's, from my perspective, Noah and Dr. Volpe may have, a clinical sense on that from their institutional and provider experiences.
On the inpatient side, my advice, and to my hospitalist friend from Presbyterian over there as well, handoff should be done at the bedside. Okay, handoff at the bedside. It's personable and it's patient-centered. You're going to get better results if the handoff is done at the bedside.
I mean, like I just say, just introducing, saying this is the new team, talking about the patient is awake and aware, making it as personal as possible. Those kind of things I can tell you from experience on the litigation side, reduce litigation, that personal, patient-centered approach. It takes some time, it can take more time, but those interactions, those human interactions go a big way towards reducing litigation risk.
I think that the other, not the question, but what I was going to say is when it comes to under-documenting, opposed to over-documenting, and how detailed it should be when it comes to
What I would say is this: solo practice doc, enterprise doc, right? Star Trek. The advantage you have as an enterprise doc is you've got a department head. You've got monthly meetings. What I would suggest you recommend, if it's not already being done, is let's go through 5, 10, whatever magical number of scenarios. You don't have to go through every diagnosis and every possible outcome. But come up, and again, this is where registry reports, which we didn't talk about, but you can come up with different reports in your system and say, these are the common things that happen in our neurosurgery department or internal medicine, pediatric, whatever. You pick the top 5%, whatever magical number you want, and let's go through the protocol. What is the preferred sign-out method? What is the preferred set of sign-out elements? Always is a little bit of wiggle room, right? That is what I think will, one, raise the level of care, because there will be people who go home at the end of their 7 p.m. shift at 3 in the morning because they're writing every possible thing. And then you've got people who shift in at 7 and go home a little bit earlier. So what you want is to come up with some sort of happy medium, right? And that is the advantage that you have as an enterprise. And now you've got, I don't know, I'm an attorney, right? So I don't know if it protects you, but it gives you, this is the standard of care in our practice. You guys correct me if I'm wrong. So this is what we do in our department. I'm not a cowboy doing what I want to do. This is what we decided as a department is important. I can always add more to it, but I probably will not be adding, subtracting from it. And I think if you do that, again, you have to invest time and energy up front. It's better for your patients, less stress for you guys, and the guy who's leaving at 3 o'clock in the morning maybe can leave at midnight, all right?
Anytime you can standardize a process, you're mitigating risk. And I think that's the simplest way to say it.
Train on it, train on it, train on it, educate, and be consistent from day to day, week to week, month to month, etc. You know, that's really important.
Sorry, one more question I have is from a patient perspective. In terms of testing, for example, there was a statement made about follow-up. With the lack of medical understanding of the patients we have, what exactly, the provider is speaking about or would like to get done. If the provider, for example, does not order a test or orders a test that doesn't follow through, and the patient actually does, and it's been, for example, 2 to 3 weeks since the test was ordered, how is the provider responsible as far as the patient perspective? I, for example, as a clinical provider, I go to the doctor, for example, and they order a test, and I'd like to get a test result back right away. But the provider doesn't get back to me as soon as I would want them to. So I'm looking from the patient's perspective. If they don't have a clear understanding as to how soon the provider is going to get back to them for the test result, how is that from the patient?
This is, I think it was 5 years ago, Columbia PNS, I think, was the first hospital that decided that when results came in, say 24 hours, I don't think it was much more than it, they went into the patient portal. Results come in, they're in the portal. Now, in all fairness to the provider, maybe they didn't get a chance to review it. Not all lab results are critical lab results, right? I think one of the things that we kind of touched upon, we talked about communication. We left out an important piece of communication, which is trust. Do you trust me, Salvatore, your doc, to get back to you in a timely fashion for things that are critical? Do you trust me, Salvatore, not to get angry at you if you call me with a question about the lab result? Do you trust me, Salvatore, doctor, if I have, again, in the enterprise, they probably have like patient-oriented literacy. So this is what a CBC is. And so when the RDW is 15, don't have a panic attack. If it's 24, could be something going on there. So that if there's trust between the patients and the provider, to one that I will do my best to get back to you quickly, but you're going to get it in 24 hours. I may not get to look at it in 24 hours. It may not have been critical to get it in 24, to review it in 24 hours. But there is some magic review time. And again, your med-mal company can give you a sense of what is timely and what's not timely. But you should also have the relationship that if you called me, I would not get angry at you as though you were harassing me. You're not harassing me, you're scared. You want to know what's going on. And you need to have peer, someone in your family, maybe a caregiver, who may be permitted with all the permissions to speak, to be with you on the phone. Because sometimes, as you know, regardless of your educational level, I'm proving it as a patient. I think half of what the doctor tells me is a multi-other, not true. But potentially, the average patient might hear stuff and not be able to process it because there could be an emotional component to it. There could be a healthcare literacy component to it. I understood 75% of what you said, but there's this 25%, and I'm too embarrassed to talk to you. Trust, if you don't understand something, patient, please ask me.
Can we take the last question?
Thank you. My name is Terry Knight, and I come from a background for learning and development. Well, this year. So my question is, are there any audits performed? And if there are, what performed with audits, especially first, regarding all this information, all the systems?
Are there audits performed? Yeah, I mean, certainly some of the regulatory bodies require you to have internal audit departments or programs in your healthcare organization. But audit can be very broad. So I'm not sure which particular, an audit of an EMR system, do you mean? There are audit trails, which are
Here, the reporting the documentation.
well, the Joint Commission comes and gives a survey every 2 years. That certainly could be considered an audit. CMS, DOH.
They come in.
One last question, please.
Hi, my name is Marcel Gavin, and I'm part of training, so I work with some of the hospitals here in New York. And my question is, or my observation is that you see a lot of, like you discussed earlier, a lot of the hospitals, without go over to the years, a lot of the hospitals look like they focus more on the cost of the training than do the providing proper training to the physicians. Like some of the user support go like for that last about 2 months. We see some of the hospitals going on for about 2 weeks. So how can, and when that happens, you see the doctors are very concerned, they're complaining, they're not comfortable, but the hospital is like this, which, the support is going to take 2 weeks. How can that be addressed? How can the hospital address that? Like the concerns of the doctors and actually provide proper support so that the staff is comfortable.
I mean, I would just say, can you hear me? I mean, I would say just the fact that, the training, as we've talked about here tonight, and I'm sure everybody's heard, before tonight, I'm sorry my mic went off, but, it's, thank you, sir.
So, thanks, Noel. I think there has to be buy-in by the organization because the failure to do proper training has real-time ramifications potentially in court. So there has to be, kind of a groundswell, a support of people to go to all the decision makers. This is again what, Noah was saying. There has to be C-suite buy-in. Yes, the bottom line is important. We can't minimize that. There are great costs and expenses every day for every healthcare organization under stress, especially again in a city like New York. But training is something that ultimately, if done well and the time is invested, will potentially reduce costs because it will reduce risk. So, somebody has to have a voice, somebody has to talk to that. There has to get, a unanimous kind of support to go to those decision makers and say, being, penny wise and pound foolish about, abbreviating the training or short-circuiting the training is really, from my perspective as an attorney working in this field, a bad idea because in this time, we have to train people often. We have to keep training people. We have to train the new people. The people who've been there have to train the younger people, and so on and so on. So this goes to everything that goes on with enterprise risk management and not having silos of different decision makers within the hospital, not collaborating with each other, but that you get C-suite buy-in from the very top down to understand that the staff, all the staff, from the physicians on down, are demanding and hungry for and want more training. They want to be, kept up to date on all the developments of all the systems. So it's a hard thing. You need advocates, union advocates, department advocates. You need to have a voice. You need to have a hearing and a place where you can say the training is not adequate. People are complaining that we're not getting enough of what we need. And I hope that's responsive to your question, but it is a vital thing to get good training, and it's very short-sighted for organizations to scrimp on that. That's just my perspective from seeing what the consequences are from not doing thorough, comprehensive training of everybody on a lot of vital issues that go on every day.
Last summer, nuclear verdicts, sometimes on the lawyers, in Commonwealth,
On what?
the nuclear verdict.
Yeah, we have a little time left, and if anybody wants to stay, and I can talk further, I would just say very quickly, we are in a very volatile and challenging litigation environment. Like with inflation, we see in many areas, there have been a lot of adverse verdicts out there of increasing amounts across the United States against healthcare providers and healthcare organizations. There's many reasons for that. We could do a whole topic on that. It is, part and parcel of everything that's going on. What happens in the world affects what happens in the courts. Jurors, the two places where the average citizen has a voice is at the ballot box and in the jury box. So, there's a lot of anger out there. We're seeing that interplay in what's happening in juries. What it means for us on the litigation side is, we have to work even harder. We have to collaborate better. We have to work together with our medical provider clients and, portray good stories, portray good results, talk about what's going on and be as proactive as possible. Not lay down, fight the cases that we can, which we're doing. There's a lot more trials going out there. We win a lot of those trials. We don't want to, tell stories of doom and gloom. When we fight these cases, we often win. We make motions. We, do a lot of things in the courtroom to protect our medical providers, and that's ever more vital in this environment. I would just leave one thing with this as the last thing, because it really resonated with me about a good story, and I think that more of our providers have to do this. We see all over the country, advertisements by the plaintiff's bar and billboards when you get out of the airport from various cities on commercials, and they can be very effective for them in gathering and capturing and obtaining new clients. It's much harder on the defense side to advertise that, we won a trial with a brain damaged baby or somebody who died and, there's little children left. But we can tell good stories. And I just will leave this with you with this, because we have seen a lot of our institutions across the city, all the major, whether it's, Presbyterian, whether it's NYU, whether it's Memorial Sloan Kettering. But for me, the best commercial I have seen in the past 10 years was what I saw this weekend watching the football game, was Montefiore Medical System. Maybe you've seen this, had a commercial with Paul Giamatti, the actor, talking about a patient who came in, I believe it was for neurosurgery. He's sitting around the table with a bunch of his friends, Paul Giamatti, not the most handsome guy, not a George Clooney, which I think was deliberate and should be deliberate. Somebody they can relate to, very clear, very relatable person, talking to his friends in a diner about what great work Montefiore Medical Center did for his friend who had a family, was a hardworking guy, and that the care was compassionate, thorough, and he got a fabulous result. Paul Giamatti says some jokes to his friends. He's walking out of the diner, and then the patient's there, by chance, obviously, for the commercial, at the diner, looking happy, looking healthy, and, it says, "Go, Paul, great result, glad to see you back on your feet." It was, not a long commercial, but I thought it was enormously effective to incorporate an actor like that to tell a story that was relatable immediately, certainly to me, and I've talked to many people about the ad. I know these ads are expensive. I know hospitals are under strains for their budgets. I think that's a lot more effective than just telling general stories, because it was very relatable right away. That's just my take on something I saw on Sunday. I think we need to do more of that. I think, people want to hear those good stories. They don't just want generalities that, Memorial Sloan Kettering is fighting cancer and doing well. Who are their patients? What are they undergoing? Maybe get people like Paul Giamatti, people like that people recognize. Doesn't have to be, some big superstar. And do more of that. Get out in the community and show the good results. Because, again, I'm not on a soapbox tonight, but, I've been in this industry for a long time. I know how hard the medical providers work and the good work they do every single day. So we have to get out there to fight these nuclear verdicts. We have to advertise our good results, and we have to find new ways to get them out there. That commercial, to me, was a great start. Let's think of others.
I think we are running out of time. How about take-home points to the audience? What take-home point with the conclusion? What do you recommend for our
Final closing statement?
Final thought, yeah.
So my closing statement from a risk management perspective, working in acute care site, would be to collaborate, right? Work with your team, your nurses, your nurse leaders, your attending, your resident, you all need to work together to provide patient care, and that's how we really drive patient care and you know, as culture of safety and safe patient care.
Mr. Rubin?
You know, I made my point with the commercial, you know, I want that to be a takeaway, but I just, you know, one last thing I would say, what Noah said is so true, you know, patient-centered care, you know, is human being care, being relatable, making that, spending that time, listening, using your listening skills, looking at people, making those connections, you know, is just so important, and that really changes things. Who's communicating, how are they communicating, constantly be working on your communication skills. It helps mitigate risk, it helps mitigate litigation, tied in with good documentation. You know, you'll see less of people like me, and hopefully you'll stay out of it. You know, the courts and continue to provide good care every day.
Dr. Volpe?
Number one, don't be penny wise and pound foolish. We already spoke about this. Invest in your staff, invest in the tech that's needed, and obviously for those of you who belong to an enterprise, work together with your fellow staff members to get the executives to understand that, and you know, maybe share this presentation with them. But it's important to communicate. So to your point goes to communication. Work on your communication skills, work on the trust, super important, cannot be underestimated. If there is no trust, there is no collaboration. If there's no collaboration, there will not be a good outcome. And lastly, invest in yourself. You know, make sure you try and set some time away for yourself. Most physicians are workaholics and tend to burn out. We have a very high suicide rate compared to other professions. I'm sure there are many reasons for that. But one of them is just a burnout. As my wonderful physician peer said, I love EHRs like he did. A lot of docs don't. Sometimes it has to do with the fact that they didn't get to pick it. Again, it was chosen by the enterprise. If the enterprise does not invest the time what you consider adequate for training, then you have to make your own judgment call. And I believe for your own sanity, you may want to set aside some time and do your own training. Supervised training by the enterprise, of course, but do it on your own time. And again, you say, Sal, you just told me not to overwork myself. And what I'm telling you is invest that time up front and you will reap the rewards because you will know where every button is that you would not have figured out for like 6 to 12 months. And if you didn't know it, you can ask someone for help. And the same goes with your staff. Make sure they have the time to get trained. Invest in yourself. Your families will appreciate it.
Closing remark? Closing remark.
My closing remark? I don't have closing remarks. I have a couple of things that we need to address. The first thing is I think that this is a wonderful presentation. We have a lot of information tonight. Some of it we were not able to go through the whole thing, which means that we need a rain check. And so at this point, I would like for us to thank our panelists and also our moderator, Dr. Attia, for this wonderful presentation. Before we leave tonight, I forgot to tell you, I think it has to do with age, that this event, this educational program, also we are in the midst of working on getting your 1.5 continuing education hours pending from NABS, CPHRM, HIMSS, HFMA, and CME medical credits for the physicians. So that's an added bonus as relates to the presentation. Also, I would like to take this opportunity to thank Emilia Soto, the executive director. There she is. We don't do this in a vacuum. My co-chair, Dennis Connolly, we work together and we work with partners to be able to get this done. And so I just want to thank her for allowing us to be here today and for also the support that she provided for this program to take place. lastly, and I promise this is the last thing I have to do, is I'm just going to briefly read one. We have certificates for our presenters, our panelists, and our moderator, and the certificate of appreciation. We do appreciate their time that it takes to prepare for this presentation and also to be able to execute the presentation. And so we are providing them with a certificate of appreciation from all the collaborating organizations, which I mentioned earlier. You don't have to go through and read all of that. And so each physician will get a certificate of appreciation from the organization to show appreciation for what they have done tonight, which I think was great. So with that in mind, that's all I have to say. I'm not sure if you have anything else, but if not, we could say good night. Get safe.
Thank you, gentlemen.